right. Welcome everybody to this Friday morning. We have the pleasure of having Dawn DeMeo speaking about sex differences in asthma and what genomics can teach us. I'm going to formally introduce her at the end of this slide set. And just to remind people about what to do if you want to get CME credit for this. If you haven't registered before, you need to go into cpd.partners.org and log in, and then choose a Mass General employee login if you have an MGB username and password. And then if not, choose a visitor login, and then complete the required fields and set up an account. Give them your profession type and your mobile number, and then click Save. And you want to add the phone number, which they'll give you, which is 857-214-2277 on your phone, because that's what you're going to use to be able to get credit. And each time we have a asthma grand rounds that you want to get CME credit for, you dial that number, and in this case, the SMS code for attendance is CAWWY. CAWWY. And you put that in, and then you'll get text messages from them about how to proceed in order to claim your CME credit. In terms of conflicts, these are the companies that I consult for, and Dr. DeMeo declares that she has been on advisory board for AstraZeneca. And you can submit questions to our speakers by entering it into the chat. And as I mentioned, the CME credit's now being awarded by the Mass General Brigham office. You can actually do MGB CPD at mgb.org. If you have any technical problems, you can send an email to BWH Webcast Troubleshooting, all one word, BWH Webcast Troubleshooting at partners.org. And so, as I mentioned, it's really a pleasure to have Dawn DeMeo speaking to us about sex differences in asthma, what genomics can teach us. Dawn is a physician scientist and respiratory genetic epidemiologist at the BWH. She's been with us for more than 3 decades. She looks a lot younger than that. And she's an associate professor with more than 300 publications, which have been focused on different aspects of lung health and disease. But she's had a particular emphasis on the genomics of sex differences across the life cycle. And we're really looking forward to learning from Dawn. So Dawn, thank you so much for being here, and take it away.
Thank you. And I'd like to start by thanking Drs. Fanta and Israel for inviting me back. So I was last here 11 years ago, and in fact, I looked at the slides and I couldn't give up a couple of them, so I brought them back. But I'm really pleased to be here. And for those of you who know me, you might think I'm a little bit of an imposter because I really think a lot more about COPD. But over the years, as that I've been at the Channing and at genetic epidemiologists, we really think about sex associations with asthma, COPD, any lung disease. And I'm going to talk a bit about that survey and highlight the complex impact of hormones on the lung. But really, at the Channing Division of Network Medicine, we believe that bringing together omics, and integrating these using mathematical modeling, using what we call network medicine, will allow us to get to 21st century medicine. And for me, it's sex-aware precision pulmonary medicine, whether it's for asthma, COPD. So I hope this talk is thought-provoking. It will be somewhat higher level to just really get through a thought experiment and maybe convince you at the end, as pulmonologists, as clinicians, we really need to think more through this sex lens. Let's see, my slides are not shifting. So give me a moment. There we go. So precision pulmonary medicine is a term that I use a lot, and really it anchors around this idea that next generation path to precision diagnostics and therapeutics is going to be through network medicine, through omics. And for me, in my research group, it's really through omic considerations that capture sex-related causes and effects in a very holistic, non-reductive, and non-biased fashion. And so from a genomic point of view, that means we need to include allosomes, X and Y chromosome data, and I'll touch on that a little bit. We need to think of the sex-aware approach to modeling the lung in vitro and in vivo as we think about the role towards clinical translation and population studies. And really, this integration of systems biology and sex differences is the way I see the next realm of innovation in medicine. Sex heterogeneity in disease development and progression is not just germane to the lung. In fact, if this is a beautiful review paper on this framework, where we think about female biased diseases, and they're diseases we've all known, autoimmune, really in that realm of female bias, non-reproductive cancers, male biased, many of them. And we can put many diseases on this framework. And we do this, but we don't really think through this lens as clinicians in a way that could really get us to treating the person before us. And we were really fortunate just before the pandemic hit to wrap up this paper and get it out the door for Lancet. And in this paper, we really proposed this framework of integration of biologic sex, which includes consideration of not only hormones, but sex chromosomes and the whole framework, together with societal constructs, and whether this is lifestyle, environment, and thinking about the epigenome and other regulatory genomes as the missing piece to really understand how to really get to understanding disease-related pathophysiology, manifestations, treatment response. And so I point you to this review if you are interested in this kind of approach to thinking about modifiers of health. Sex differences in general, not just in the lung, have been recognized as one of the most significantly understudied aspects of human disease research and therapeutic innovation. I mean, many prior experimental studies and clinical trials haven't included equal number of males and females. Sex chromosomes, as I said, have been excluded. And I return to this a lot because it is an area of my own research. Over a decade ago, the NIH mandated that we needed to consider sex in research design, analysis, and reporting of the findings. I just want to be clear that sex is a biologic variable to distinguish it from gender. And if there's time at the end, we can touch on that distinction. And this really got me to thinking early on, understanding and accounting for biologic sex differences can really get us to better disease prevention and treatment. And as we've ignored this in research, we've ignored it in clinical care. And so past biases that drove this, again, not only in lung disease or allergy, but just in general. There was a belief that results from one sex, i.e. male, could generalize to the other. And so the male became the default subject. A lot of studies, even now, fail to report or analyze data separately by sex. And we talk about this a lot in some of the more current clinical trials. We're still doing this. We don't disaggregate data. And just getting back to sex chromosomes, only 25% of genome-wide association studies have included the X chromosome data, and even less, 3%, the Y. And again, both of these chromosomes are critical to lung disease. So for those of you who are listening in who don't think a lot about sex differences in asthma, so we know that asthma is a highly prevalent chronic inflammatory disease, greater than 300 million globally. Numerous studies have supported asthma differences by sex, with young boys nearly twice as likely to develop asthma than young girls. And women, after the pubertal transition, have fluctuating asthma severity post-puberty. And I think if nothing else motivates us to think through this lens of sex in the genome, it should be that. And I'll touch on that momentarily. Most studies of asthma in the past haven't accounted for clinical sex, for biologic sex. And when we take a history in the pulmonary or the allergy clinic, we definitely are not rigorous about asking men and women about hormones. And I think that's, or even considering this, whether a woman's on oral contraceptives or whether a man is using testosterone therapy. So I think we really need to add this to our clinical EPIC review. So this is one of my older slides. I had to bring it back because the epidemiology of these sex differences is not new. We may think it's new to think through this lens, but back in the 80s, actually in the 1970s, Ben Burrows and colleagues were already thinking about what they were observing when they looked at age-specific incidence rates for asthma in Tucson. And in the youngest age groups, females had lower incidence. The incidence was greater in adult women. over the age of 40. And this has been replicated over and over. And if we look globally, if we look at global data, health exchange, or even at just CDC data, we can see across the life course with age on the x-axis and asthma prevalence on the y-axis, we see this male young boy prevalence of asthma, and then this declines as asthma rates in females rise, and then across the life course, we see this female predominance. And this is not just a US trend. This is not niche. This is what we see globally. If we think about markers of asthma severity, hospitalizations, again, one of my older slides, because this is a really great study that had me thinking about sex differences in asthma when I was a fellow. This group noted under the age of 10, boys were hospitalized twice as often as girls for asthma exacerbations. And then if we think about severe asthma distribution across the ages, data from the Severe Asthma Research Program, SARP, again, recapitulated this age. If we look at this plot on the left, age on the x-axis, we see this bimodality of asthma prevalences by age. In terms of looking at healthcare utilization across many population studies, as well as SARP again, in terms of healthcare utilization, predominant in women compared to men. The heterogeneity of many complex diseases like asthma start with differential impacts of exposures. And when we think about the lung, these impacts can be dimorphic. So exposures may exert differential impacts because of sex-related biologic factors. It may be because of social constructs, but it's probably some complicated interaction. So if we think about different environmental exposures and the associations we've seen in the literature with asthma, of course, cigarette smoke is a complicated one, and I won't perseverate too much here, but if we think of other inhaled exposures related to occupations, we see variability in the sex differences, whether we see increased rates of asthma in men versus women, and we can see this across dust, fumes, and these occupational exposures need to be just as part of our intake evaluation of the patient coming to us clinically as the hormone, because we can really think through this gene by environment lens more effectively. And if we think about this bidirectionality of what may drive sex and gender differences in asthma, we really need to think of this integrated model where we not only think about childhood factors, social environment, comorbidities, but this is where this complicated set of what are the hormone changes across the life course that are impacting the genome, and what are those genomic differences that have started to emerge, whether it's gene by environment interactions with genetic variation, non-sequence-based variation, epigenetic, and I'll touch on all of these. Again, this is a big topic, and for those of you who know me, I could talk for a long time on this, but really to give you this lens to start a conversation and really to transform how we think about precision medicine. Summarizing some of the epidemiology, because genetics is only as good as our epidemiology. If we think males versus females in the context of asthma, we really want to take in the epidemiology of childhood prevalence, higher in males, switches at puberty, lower in females until that point, and then this prevalence of asthma in higher in females persists across the life course. We'll talk about all of these other biologic constructs, hormones, immune response, but then really just therapeutically, we know that there's a bunch of studies that suggest that there's lower corticosteroid response in females, especially in the setting of severe asthma, that females may have more airway remodeling. And so to not think of the omes, the genome, the genetics, the omics through this lens really prevents our ability to move our innovation forward. And so we think about network medicine as starting through building layers. How can we build layers through the omics of asthma, including genetic sequence-based variation, non-genetic epigenetic variation, changes in gene expression, changes in the proteome, changes in the metabolome, changes in dynamic genomes, somatic mutations, and then the overarching effect of hormones across all of these. We need to do this if we really want to get to a better understanding. And again, this is not just relevant to the lung, but we know that sex-specific genetic architecture has been described for a host of human traits, including lung function, and that when we fail to model this sex-specific genomic and genetic architecture, it really hampers our ability to understand the role of genes in human disease. And I will return to this many, many times. Ignoring the X and Y chromosome has been standard. And I get asked this question a lot. Why have we come to this? Why can't we really recover this part of the genome? It's because the methods are a little different for analyzing these data. And usually when we started on this genomic era, those data were just used to verify biologic sex and then thrown away. And so as we think of genetics, we really think of it starting with genetic susceptibility, but then that susceptibility sets a framework for each of these additional omes, whether it's the epigenome or other endogenous factors interacting with the system, with the genome. So from the candidate gene era, we identified in the literature various genes, some of them listed here, this is not exhausted, that demonstrated differential association by sex for asthma outcomes in males and females. And for those of you who think mathematically, how can we really have populations big enough to feel that our findings are powered and true? And I think that is a really important question because not all of these have been robustly replicated in large-scale studies. But I think the overarching trend is whether we look at beta-adrenergic variation in beta-adrenergic receptor genes or some of these other genes in inflammatory and immune pathways, sex differences were observed. And I think just to point to two of them, the variation in the estrogen receptor 1 gene was really interesting. It was associated with airway hyperresponsiveness and lung function decline, especially in females with asthma. And then the HSD3B1, where evaluation of this gene in SARC was notable for differential response to glucocorticoids in women. And regardless of what each specific gene is, I think the framework started us thinking through this lens of gene by sex interactions as an important part of asthma genomic discovery. So where we are now? So where we are now is we sequence whole genomes. We have large-scale populations like the UK Biobank, which is hundreds of thousands of individuals. So these data on what we call genetic risk scores are from the UK Biobank. And what is done to develop a genomic risk score is we start adding up the genetic risk across the whole genome. And if you look at the plot on the right, where we have genomic risk score deciles on the x-axis and odds ratios for asthma on the y-axis, the group that analyzed the UK Biobank data noted at the highest deciles of genetic risk, we see a predominance of males. Now, this was across all age groups. It was really fascinating because what's missing is a lens of age and life course when we do genetics. Remember, unless someone develops mutations related to, cancer, our genetics are set from birth. So we could potentially model polygenic risk for asthma in everybody. But the environmental experience is very personal, and hormone milieu is a subset of the environment. So thinking about this kind of susceptibility framework may explain why young boys have more susceptibility. But it's that gene by environment piece that takes this genomic or genetic risk and really leads to what we may see across the life course. So this is one comprehensive example of a sex difference in genomic risk. But in this beautiful paper, they dropped the X chromosome. So subsequently, we were really intrigued by this. And this is maybe one of two slides on COPD I'll add, because in COPD, we think a lot about sex differences is where a lot of my work is. And we brought back the X chromosome data in our COPD cohorts, and we tested for association with lung function and found X chromosome variation associated with a specific gene associated with lung function. And it really highlighted for us the need for a comprehensive interrogation of the X and Y chromosome And really, as we think about asthma, we need to do the same. And so some of the work from Joe Zane last 2 years ago, he went back and analyzed a similar subset of UK Biobank data and parsed the data by sex, looking for specific genetic variants associated in males and females. And when he did that, he found genes that were associated uniquely with males, uniquely with females. He included the X chromosome. You see it at the end, and there's not a lot of genetic association going on there, but I'll talk about that momentarily. But what was really important, so this is a really nice example of making sure we do the right statistical tests to define whether or not there is a gene by sex interaction. So Dr. Zane modeled very carefully not only the sex-specific genome-wide association, but compared the odds ratios in a very rigorous fashion. That took down hundreds of genetic associations to 8. And we see them colored here in red. And there was enrichment across the genes associated by sex in Th1 and Th2 inflammatory pathways and other immune pathways. But really, the global evidence that genetic variation drives asthma differences was really marginal. And I think this is an important message as we think about not just looking under the lamppost of genetic sequence variation, but all of the other regulatory ohms that may be relevant. And that made sense to me. So when I was 10 years ago, when I was getting ready for this talk 10 years ago, I found this paper, which I think verbalized what I was thinking, which really pointed us to this idea of sex differences in quantitative phenotypes. Lung function is a quantitative phenotype. Lots of intermediate phenotypes of asthma are quantitative phenotypes. But from a genetic point of view, the fact that we see sex difference is a bit of a paradox, because the majority of genetic material, except the sex chromosome variants, are shared between the sexes. So how can we see across many diseases, many traits, such profound sex differences? So it really takes us back to thinking about gene regulation, epistasis, gene-gene interactions, or other aspects of the genome and genomic variation. So if we think of some of the interesting studies in gene expression, Joe Zane and Ben Gaston and Nima Sharifi published a really interesting study looking at gene expression and androgen receptor expression in airways. And what was really interesting was in androgen receptor gene expression in airways, there was similar risk associated with this particular gene expression. And one of the things that was really interesting to emerge from the transcriptomic literature, in addition to that finding, was that higher androgen receptor gene expression in bronchial epithelial cells and higher androgen levels in general were associated with better lung function, fewer asthma symptoms, and lower FeNO in patients in SARP. And I think this really is important because we may not always see differences in transcriptome and gene expression, but it's pointing us to a framework. Here, the framework is we need to really think about the sex steroid receptor genes as well as the genome. And just one more study that leveraged this difference in variable gene expression. Again, Dr. Zane's group looked at pre- and postmenopausal gene expression differences in women with asthma and saw very significant gene expression differences related to immune system and mitochondrial function. And so this idea of how do we unpack what may drive sex differences in asthma? There's comparing males and females, looking for what's happening with hormone receptor genes, but then there's also thinking about the special case of women, and we'll talk a bit more about that momentarily as well. But this idea of not just looking at puberty as an important time for defining sex differences in asthma, but the different hormonal transitions, whether it's menopause in women or the andropause in men, which occurs around midlife a little bit later, is really important if we want to do better by understanding asthma. So a lot of my work focuses on the epigenome. So what is the epigenome? So broadly and easily defined, it's an element, a regulatory element that allows for changes in gene expression but it's not associated with an alteration in DNA sequence. And I like to say, if we think of the DNA sequence as our genomic alphabet, as a series of musical notes, the epigenome is like the composer notes that tells the genome what to say and how to play. And one of the oft-studied epigenetic marks is DNA methylation. And DNA methylation involves the addition of a methylation group to DNA. And one of the really interesting parts about DNA methylation is plastic across the life course. And it really allows us to capture an archive of the environment of exposures. And it's very hormonally sensitive. So one methylation study, again, if you're interested in understanding what may drive sex differences, I always like to talk about this one. So this group noted that variable methylation was associated with the sex switch of asthma in adolescents. So this group looked at DNA methylation of across the genome and noted that differential methylation of interferon-related gene was associated with sex-specific emergence of asthma in girls after the pubertal transition. And puberty is such a time of metabolic frolic. There's such a transition going on in many domains. And so it makes sense that some plastic element of the genome is getting perturbed and pushing a system towards a specific space. So we have, through the NIH, have a lot of DNA methylation data across the life course, including in asthma populations, where we're unpacking this further. But DNA methylation is also important to the behavior of the X chromosome. And I'm bringing this up not because I have any data to share, but because it's a very under-investigated area. So males have one X chromosome, females have two, and one of the X chromosome in females gets methylated. DNA methylation shuts off one of the X chromosomes in a random fashion. And this is a beautiful paper that describes the landscape of how this X inactivation behaves across human tissues, including the lung. And what we know is that some clever genes escape this inactivation, and that these escaped genes may be implicated in lung diseases. And so one of the ways in which we need to do a deeper dive into DNA methylation is to unpack what's going on with the X chromosome in asthma and COPD. One of our junior faculty is working with me on this in COPD, but in terms of asthma, it really is an under-investigated aspect of DNA methylation and sex differences. Sex differences can be described for any OME associated with asthma. And so, like I said, this is a big topic, and I can't go through every study. If you're interested in this, drop me an email, and I'm happy to get a coffee with you and go through every study. But metabolomic associations with asthma exacerbations are one example that has emerged demonstrating sex differences. So this is work done by Dr. Priya Kachru, who's now junior faculty at Rutgers, when she was with us as a postdoc. And she observed across a metabolic study, a very comprehensive metabolic study, that males and asthma exacerbations had associations in certain pathways, fatty acids and corticosteroid metabolism, whereas females had associations with carbohydrate and amino acid metabolism. One example, there's a lot of metabolomics work going on in our group at the Channing, with Dr. Jessica Su, but this particular study suggested that DNA metabolomics may underlie sex-specific features of asthma pathogenesis. So we're slowly picking our way through polygenic risk, transcriptomics, epigenetics, metabolomics. In fact, the proteomics literature is emerging. There's not as much information, but the proteome is a highly important area to study. We're seeing a lot of sex differences in the proteome related to cigarette smoking and associated with COPD. And we just received a tranche of data from the NIH TopMed program that we're going to study sex differences in the proteome of asthmatics. But at each layer of these OMEs, we can think about the individual behavior, or we can join together these layers with the genome. But none of that is as effective as if we join these together with hormones, sex, and time of life, age. So age is the inevitable, but hormones can fluctuate. And I think this idea that sex differences and steroid effects in the lung are meaningful. This is not a new idea, but I think it's gaining traction more recently. And we can look at some of the really excellent reviews on this topic that have looked at allergic disease, asthma, COPD, and understand both the clinical impact of these hormones in the lung, whether it's related to Th1, Th2 shifts, the role of estrogen as an exacerbator of inflammation and testosterone as or androgens as anti-inflammatories, and some of the experimental work that disaggregates the estrogen, progesterone, and testosterone effect. There's a lot of old literature in this space, and there's a lot of emerging literature in this space. And what do we understand about hormones? Well, they kind of parallel what we're seeing in terms of sex differences. We know that asthma severity can vary with hormonal cycling. We know that there's this pubertal switch. We talked about this. But then there are the other things we see that are germane to women's lung health. Premenstrual asthma severity, the increased severity associated with polycystic ovary syndrome, pregnancy associations where 1/3 of women may have a much severe worsening of their asthma, the transition of menopause and andropause. And so investigating how sex steroids may influence asthma treatment response has really been limited. But investigating how, from a pharmacogenetic point of view, the genome and hormones may drive these different treatment responses or these different clinical manifestation. Great area for investigator interested in this space. So just a couple of slides I think are important, and they were left from my deck 10 years ago. And I just think they were really important studies to me when I was learning about this. So catamenial asthma, all of us have taken care of people with fluctuations in their asthma, women as they go through their menstrual phase. But this was started being noted in the 1960s, that some early studies suggested a high prevalence of catamenial asthma, or catamenial meaning menstrual cycle related asthma. And this has been observed again and again. But when we see women in the pulmonary clinic or in the allergy clinic, are we asking them those questions about the association of their menstrual cycle with their asthma, or oral contraceptive use with their asthma? Again, reverting back to the UK Biobank and some of the large data sets from NHANES. So these are really massive data sets. And what we started to see was associations between sex hormone variation and asthma prevalence. In the UK Biobank, elevated free testosterone was associated with lower odds of asthma and current wheeze in both men and women, and a lower odds of asthma hospitalizations. Estrogen is a real interesting hormone, and I think we really need deeper dives, because sometimes estrogen and estradiol looks pro-inflammatory. Sometimes later in life, it may not be so. So more information is needed. I'd like to always share this study because it's a reminder to those of us who think about the lung health at midlife. This is an important study that came out of from Kai Triebner, that noted menopause was associated with accelerated lung function decline, and that clinicians really need to be aware that respiratory health can deteriorate during reproductive aging, whether or not someone has poorly controlled asthma. And so again, bringing this lens of asking about hormones, irrespective of what we're thinking about, the genome and the translational relevance of the genome is really critical. And this sex steroid signaling in the lung is really critical when we think not only of the normal airway, but the asthmatic airway. And if we think of the asthmatic airway, all of the hormones, testosterone, estrogen, progesterone, they're all impactful. And these impacts are cell-specific. They have specific impacts on mast cells, on eosinophils, on all the genes that we have found genetic associations with in different fashions. And I think as we think about this severity of estrogen in women and how to really unpack the genome, we need to understand that estrogen signaling plays a critical role in airway inflammation that is bespoke by cell type. And so when we do large-scale epigenetics or other omics, we try to deconvolute the signals down to cell specificity, because if we think about how are we going to build a better therapeutic, or how are we going to get to primary prevention by sex, we really need to have this lens of the variability of of these cells and the sensitivity to hormones, how that may be sex specific, how it may be impacted by genetic and genomic variation. And it's a complicated story. And so animal models have suggested that estrogen increase in testosterone may decrease Th2 inflammation. Again, how can we think about biologics and the impact of biologics on Th2 inflammation if we're totally ignoring this other piece of knowing that life course and hormonal variation matters? And so we know that sex hormones have variable interaction with immune genes. Some of those immune genes are listed here. But as we think about integrating omics and hormones, we understand the following: that the influence of sex on the natural history of asthma varies across the life course, and this life course variation is probably related to hormonal influences both on lung growth and development and changes on airway reactivity due to very cellular level impacts. Hormonal influence on immune modulation may be manifest in area of responsiveness, but really bringing it all together is a problem of multi-omics integration and what we like to say across the street, network medicine. And as we go from where we've been to multi-omics integration to where we want to go, we really need collaborative work to bring this all together, to understand not only the mechanisms of sex differences in asthma, but what are the sex-specific biomarkers that will teach us something about asthma risk and severity, and how do we really get to this precision pulmonary medicine through the lens of sex? So does sex matter to precision medicine? Yes, because it not only tells us something about treatment response through pharmacogenomics, but it allows us to better stratify patients, to get to target discovery, and really bringing together all of what we understand about the genome, polygenic risk, gene by environment interactions, will really get us to this next phase of innovation for asthma care. So what is network medicine? So we're at the Channing Division of Network Medicine, and we really embrace some of the work that's been promulgated by Drs. Laszlo Barabasi and our own Dr. Joe Loscalzo, that key components of thinking in terms of networks. It's holistic rather than reductionistic. It allows us to take these layers of the ohms and build networks. And the benefit of networks is that we can capture nonlinear responses. One gene does not equal one phenotype or one outcome, and we can really capture emergent properties. And it inherently employs systems biology methods. We bring it all together and we see what comes out. And again, as I was thinking about how I wanted to think of this lens of sex differences and lung disease, I was very influenced by the work of Art Arnold and Dr. Lucis. And here, they really started to promulgate early this idea that systems biology will allow us to ask new questions about systems, sex differences. Because up until they really formalized this idea, we had single gene investigators unaware of the methods and attitudes of systems biology, and systems biology not really thinking about sex differences. So they came up with this framework of the sexome. And the sexome really allowed us to think of integrating sex-biased features of gene networks and cellular systems, and to think of the sum of sex-specific and sex-biased interactions and how those elements connect. And it allows us to refine these layers of the ohms. And I've only touched on the individual layers, like scrape the surface of the literature we have supporting individual layers, but it really allows us to merge it all together with this awareness of biology and hormones and how society and environmental exposures may be impacted. So this has been my motivation, to get to a path of precision pulmonary medicine for the care of patients with obstructive lung disease by combining genomes and environments, hormones, to build better networks. And in our case, we've done a lot of reconstructing regulatory networks. And these are methods that were really spearheaded by Dr. Kimby Glass and John Quackenbush. And it starts from thinking through this lens. And again, this is just one approach to build networks in the lung. Of thinking about how proteins and proteins interact, think about how transcription factors may differentially bind in the genome, how they may impact gene expression. We put that all together using a mathematical algorithm and we build a network. And here and edge weight is representing the likelihood that a given gene, so here an asthma gene, might be regulated by a given transcription factor. And we can do this at the level of a population, or we can build these networks at the level of a patient. And if we're thinking through the lens of sex, we could build female-specific networks and male-specific networks. And this is what we've been doing. And we've been doing this with this idea that we want to compare male-specific regulatory networks and female-specific to come up with an idea of sex-biased gene targeting, sex-biased pathways, and sex-biased gene communities that may allow us to understand pathobiology at a higher level for males and females with lung disease, and then use that information to get to novel therapeutics. Understanding networks and understanding how networks relate to sex difference is broadly applicable. I think about this in the lung, but understanding these network features will allow us to think of any sex-specific outcome, and it's an area in our group of methods development, and we're really excited about this. So one of the earliest papers we did was we took this idea and we brought it to a compendium of gene expression data in 29 human tissues. And this is work done by Dr. Camila Lopes-Ramos, who's junior faculty at the Channing now. And we looked across all human systems. We had over 8,000 samples. This is not just lung disease, or these are normal tissues, including lung. And we compared the networks of males and females based on just gene expression, protein-protein interaction, and transcription factor. And what we found over and over is that we didn't see a lot of differences in gene expression, but it was really in how genes were regulated. Again, this goes back to, we don't really expect to see big differences in genetic sequence, but we see a lot of difference in phenotype. So something has to be active there. And in addition to that pattern of seeing sex-specific networks, we started to see a repertoire of transcription factors with sex-biased targeting. And so we took this into the study of COPD, and what we were able to discover, this is a paper published about a year ago, that if we use these methods we instantiated, we could see profound sex differences in COPD and sex-biased regulation of genes in the extracellular matrix. And we took those gene regulatory networks that had sex differences in how genes were targeted, and we looked at differences in gene expression and also DNA methylation. And now we've looked at the other omes, and we're coming up with an integrative framework for how a network may teach us something better. And one of the exciting things about networks is that we can mine the edges and do drug repurposing. And so we're really excited to take that forward. And in severe asthma, other groups have been thinking about this framework of how do signals meld together. And so whether it's a graphical model, thinking about how sex and gender may interact with severe asthma and where sex hormones and genetics and inflammation and aging all fit in, recognizing that there are nodes and there are edges and that we need to think more integratively and less reductionistically is really where we are. So in our group, we believe that there's a promise of network medicine to get to precision pulmonary medicine. And for my own work, that this is through understanding sex bias regulation at the systems level, that as we understand this, it starts with good epidemiology. And we really want to get to this framework of identifying distinct regulatory processes. And one of the innovations that we've been able to achieve is bringing the X and Y chromosome back into these models. And this is a funded work that Dr. John Quackenbush and I are doing to really think about creating complete networks to better model the lung. And if we do this, we may avoid missing important signals related to therapy. So as we think about everything we could avoid if we bridge this gap of bringing together the omes in this framework of understanding what has more signal in female and male, it really can get us to this consideration for an opportunity for sex-aware drug repurposing. And sex-aware drug repurposing is not just bringing together genomes, it's bringing together environmental considerations, hormones, and building this framework where we have to embrace, although drug trials may show no difference in effect of a specific drug, maybe if we look under the hood more deeply, we may see sex differences that could inform better management of our patients. And although thinking about a lens of sex as a biologic variable in the lung has particular challenges, if we want to think, how do we validate? Many cell lines have lost their sex chromosomes. We don't know the sex, or there's hormone differences in murine models or other models. But there's always solutions to these. And we and others have published on best practices for doing recursive research from the bench to the bedside and back again that will allow us to understand these sex differences and innovate to therapeutics. So what about artificial intelligence? No talk on genetics and genomics is going to be complete without a comment on AI. There are groups that are thinking about fair AI and the biases that may emerge if we're not really thinking comprehensively about the sex differences in model training. And that includes thinking through this lens of sex and gender. And as we think in terms of building foundation models of the genome, we really need to remember that we have to include sex chromosomes and we have to build comprehensive models that address these important differences. And for those of you who attended last year, the first author, Dr. David Cerrillo, came and spoke last year at the Brigham and just gave a really important reminder that this is work on the growing edge, whether we're using large language modeling of EHR for asthma or otherwise, we really need to think comprehensively. So as I come to a close, I just want to share that my view has always been we want to promote equity in pulmonary health. And my work has really anchored around big data discovery and partnerships to really get to this idea that we can develop biomarkers and better therapeutics. We can get to this reality of precision pulmonary medicine if we think through this lens of sex. And if we think more broadly in terms of sex differences in asthma, so what has omics taught us so far? That some of the significant sex differences we see in asthma incidence and prevalence across the lifespan have associations with omics, but these associations are occurring in a hormonal context. Estrogen as a pro-inflammatory and androgens as an anti-inflammatory are driving our genomes in different ways. And that network medicine may provide an integrated framework for genes, environments, and hormones. But what is the holy grail here? It's to get to better therapeutics, to better preventatives, and multiple knowledge gaps remain. And we really need to think about the research and the role of hormones and hormone modifications. Is supplementation the right approach? Should we be measuring hormones when we do drug trials to understand why there are non-responders? Is that happening because of different hormonal milieus? There's a lot of opportunity and there's a lot of need. And so I'll just leave you with this question: does sex matter for asthma? And I think this comment has always spoke to me. Sex does matter. It matters in ways we don't expect, and undoubtedly it matters in ways we have not begun to imagine. This was promulgated over 25 years ago, and I think it's still true now. And as I wrap up and say thank you, I just want to acknowledge a lot of my research funding from the NIH. I'm funded by the Alpha One Foundation. And I'm really particularly grateful to the NIH. I have a mid-career K-24, which allows me to mentor people in patient-oriented research in sex-aware data science of the lung. So if anyone listening is interested in talking to me more about opportunities in this space, please reach out to me on the MGB system. Thank you very much, and I'll end here, Dr. Israel.
Oh, Dawn, that was a fantastic discussion, a wonderful overview on an area that I think a lot of us aren't thinking about enough. And the first question I see in the chat, I encourage people to put questions in the chat, is can the dramatic hormonal changes that transgender persons undergoing gender change experience teach us about hormonal influences independent of genetic sex?
Dr. Fanta, this is an important and timely question. I think the answer, of course, is yes. We want to take care of every patient that comes to us in the clinic. I think some of the important publications by Dinah Forer in the allergy group have really started to address this. There have been some important papers that have been published in this space. Even this month, a proteomic paper that suggests that disaggregation of chromosomal sex with hormones may lead to different proteomic profiles associated with immune pathways that associate with asthma. But again, I think we need to be able to do this research, and this research has become a little bit fraught right now. I think as we think about how to take the best care of people with dramatic hormone changes, I think we need to address the patient in front of us. So the answer is yes, that's the short answer. I think it's a much more nuanced response because a lot of groups that have been working in this space have had to stop. And I think if we can't do the research, we don't have that same promise to take the best care of the patient in front of us. The other, yeah, so I'll stop there, but the answer is yes.
To follow up on that question, has there been anything that's been learned from these exogenous hormone involved in these in these gender transitions in terms of that helps us understand more about what you're talking about in terms of hormonal influences?
Yeah, absolutely. I mean, I think there's been some observations that especially XY individuals transgendering and taking exogenous estrogens sometimes have marked worsening of their asthma symptomatology. And we have to remember that that's happening in the context of gene by environment, is happening in the context of exogenous hormone effects on the lung. And so I think the additional question for those of you who read the New York Times, there's a growing interest in women taking testosterone, not for transition, but just for general health. And I think a question is that going to be a good thing for the lung or a bad thing? And I think we need to be able to study this hormone interaction and effect, not only in the context of the hormones, but in the context of the genetic susceptibility. So I don't think it's only about transgender individuals. I think it's about the impact of exogenous hormones, whether it's testosterone, oral contraceptives, hormone replacement therapy, or DHEA, anything that may perturb a hormonal balance and interact with the genome and have an effect on inflammatory pathways in the lung. I think the other question is not hearing a lot about animal models. There's a tremendous and rich research on murine models of sex difference in asthma. And I think that's a whole other talk. But there are animal models and there are research groups that have really taken to task to model male and female mice, to model those hormonal perturbations, to do castration models, to do ovarectomies, and really see differences in response to house dust mite and things like this. So the animal models have been very helpful at understanding the relationship between hormone effects in the lung, for sure.
Okay. There's a question. Jessica Sue had a recent publication on the value of sphingolipid steroid ratios in predicting asthma exacerbations. Did they look at male-female differences?
I'm not sure which paper, but I did mention a paper by Dr. Priya Kachru and Dr. Su is the last author of that paper, where in that asthma exacerbations, there were different pathways that were associated in males versus females. I think that's the paper you're referring to. And in the males, it was fatty acids, sphingolipids. And so I think through this metabolomic data, we really are getting closer to what actually is happening. And we do see sex differences. And I will say, we see very similar metabolomic differences in COPD by sex as well. So I think taking each ohm and where we see commonalities by sex in COPD and asthma may get us to, again, as we streamline some of the drugs that we repurpose for asthma COPD overlap, or whatever that middle point is, we want to learn about sex differences from both diseases. And so, we see these metabolomic differences in COPD as well.
And so you mentioned or alluded to a difference in the response to exogenous steroids in men and women in asthma. Are you aware of, we're all very excited about the use of biologics in asthma. Are you aware of any information on sex differences in terms of the response to the biologics?
Great question, Dr. Israel. And I think it's an important one because many of the biologics have not disaggregated their data by sex. I can say, I can give one example. So, dupilumab, there's similar efficacy in males and females. However, in a real world follow-up data set, it does look like that male sex and higher EOs may associate with better response compared to the response we see in females before age 50. And so that's a study, I think it was from 2025 or 24. And I think that part of the limitation to date has been a lot of the newer drugs haven't even the older drugs haven't disaggregated data by sex. And there's been a concern that the request to disaggregate data may change over time, and maybe thinking through this lens of sex may be de-emphasized a little bit. But I think as clinicians, we definitely want to think, if we have a patient on biologic and they're not responding, could hormonal milieu be an issue, right? In the context of all the other things that may drive non-responsiveness. I think hormones interacting with genetic susceptibility or other omics may be an important feature. And so one of the learning points I hope people take away is there's an opportunity here. If you have a male who's not responding to a biologic, maybe check their testosterone and think about that opportunity to think about the patient in front of you.
Right. There's another question about whether differential responses to cigarette smoking influences asthma in different ways in women versus men.
Yeah. Likely, and if we look at male-female differences, whether we're talking about asthma, COPD, or other lung diseases, I think what we understand is that for every cigarette smoked, women can develop more severe lung disease at an earlier age. And so I think what's confounded the literature about cigarette smoking and lung exacerbations or lung susceptibility is that women get there with a whole lot less exposure. And so I think as we think in terms of cigarette smoking or vaping for that matter, I think it's really understanding that these exposure burdens can be a lot lower for women to experience the pulmonary effects. And whether that's anatomy, physiology, hormones, I think it's complex. But, I think by sex, we do see some of the literature suggests that males who smoke have more severe asthma exacerbations. But if you look within females who smoke do worse than females who don't smoke. I think that's not surprising, but I think there's a lot more nuance there. And some of that nuance, so a couple of years ago, we published on epigenetic differences related to cigarette smoking. And we know that there are profound sex differences in genes that are differentially methylated associated with cigarette smoking. So again, to answer that question in the most comprehensive way, Dr. Fanta, I think we need to go back to some of the omes, especially the epigenome.
Okay. And there's a question in the Q&A. Let me just pull that up. So would inclusion of sex in models as a confounder account for these differences, or does sex need to be considered specifically as an effect modifier?
That's a fantastic question, and there's a lot of literature on how to best model sex differences. Including sex in the model is not adequate. Because what you're doing then is you're kind of adjusting away sex, but you really need to model interactions. And, but interactions are hard to see because many studies may be underpowered. But looking for an interaction and stratifying your models, non-genetic models, just epidemiology is a critical step. When we're in the genomic space, doing that and including your sex chromosome effects are critical. And so if you're looking at the Y chromosome effects in males, obviously there's no interaction to model. So some of it is modeling the interaction and not making the mistake of saying you've assessed for a sex difference when you've not modeled that interaction. But then thinking about what the question is. And obviously you're going to ask a Y chromosome question in men only.
Great. I think we've reached the top of the hour. So again, Dawn, thank you so much. This was really a wonderful talk and really stimulating in terms of ideas that we may not have thought about. And just to remind people, if you want to get CME credit, please text to 857-214-2277, and the code is CAWWUY. Thanks again. We look forward to seeing you at the next Asthma Grand Rounds. Have a good day and a good weekend. Thanks again, Dawn.
Thank you.